Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the role of aerobic exercise in relieving pain for ovarian cancer survivors with Dr. Leah Ferrucci and Anlan Cao. Dr. Ferrucci is an assistant professor of epidemiology and chronic diseases at the Yale School of Public Health, where Ms. Cao is a graduate student. Dr. Chagpar is a professor of surgical oncology at the Yale School of Medicine.
So maybe we can start off with each of you telling us a little bit more about yourself and what it is you do. So Leah, maybe we'll start with you.
Sure. So I am a nutritional epidemiologist, and I actually trained here at the Yale School of Public Health for both my master's and my PhD. And as part of my PhD, I was able to also be a part of research at the National Cancer Institute. So I had that unique ability to work with strong investigators here at Yale as well as at the NCI. And so my work has really focused on thinking about diet as a risk factor for cancer incidence, risk of cancer. And then in the last few years, I have taken that to think about diet in the context of cancer survivorship and how we can think about not only diet itself, but also energy balance, as well as physical activity, another lifestyle factor in the context of thinking through how we can improve outcomes in cancer survivors, whether it be quality of life or perhaps even ultimately survival.
Fantastic. And how about you, Anlan?
I'm a fourth-year PhD candidate, and I'm also Cancer Prevention and Control Predoctoral Fellow at Yale Cancer Center. Professor Leah Ferrucci here is my mentor, and I'm also mentored by Professor Melinda Irwin. Before coming to Yale, I was a preventive medicine major in college, and I received my Bachelor of Medicine in China. My current research centers around cancer and nutritional epidemiology with a special focus on lifestyle factors and ovarian cancer. And I entered this program because I just loved epidemiology. And I'm not saying this because my professor is here and she teaches epidemiology, actually. But in my first interaction with epi, the study designs and the philosophy behind them amazed me. And I was like, I definitely wanted to get additional training in this. So I entered this program and I specifically focus on cancer and lifestyle because we've all been hearing about the compromised quality of life of cancer survivors and how researchers and physicians should pay more attention to it. So I'm paying attention. And lifestyle factors to me are really powerful because they are highly modifiable. And if we found that lifestyle interventions like what we do here can actually improve quality of life, prevent recurrence, and improve survival for cancer survivors, then these lifestyle interventions could be valuable additions to the current standard oncology care. And I think that's where I'm working towards.
Yeah, no doubt. I mean, if we can really hone in on lifestyle modifications, not only might that be a benefit to cancer survivors, or cancer patients, or even preventing cancer, but could have offshoots of reducing heart disease and stroke and all kinds of other ailments, and it might be a really cost-effective intervention too. So let's dive into your research a little bit more. Leah, do you want to tell us a little bit more about your current studies and what you're doing and what you're finding?
Sure. So the most recent study that we are working on together, that we've worked on together, is one where we are looking at an exercise intervention among ovarian cancer survivors who had already completed chemotherapy and were sort of described as a little bit low in their physical activity. So they couldn't have been doing more than 90 minutes of physical activity a week. And so what we were trying to look at here is if we were able to increase their physical activity, would we see an impact on a very common symptom that's related to chemotherapy, and this is known as chemotherapy-induced peripheral neuropathy, or CIPN. So here again, we had this exercise intervention in place. It was 6 months long, and it was home-based aerobic exercise. We'll probably go into a little bit more, but mainly the women in our study were able to do this by doing just brisk walking, so something that is accessible to many individuals. And so over the intervention time period, we had one group receiving this exercise program, and another group receiving just information about ovarian cancer survivorship. So that comparison group we call an attention control group. So we're giving them the same contact with our research staff and really trying to isolate, is it the exercise or is it the attention that someone is giving that might have an impact on our outcome? It's also important to keep in mind for this particular analysis that we were looking at what's known as a secondary outcome of the original study. So this study is known as the WALK trial, and the primary outcome for that had actually just been health-related quality of life overall. And we did see benefits for the exercise intervention for that primary outcome, specifically with physical-related, health-related quality of life. But in this analysis, we cut to kind of relook at our data and see, is the intervention specifically also impacting this key symptom that we know about or key side effect that we know about related to chemotherapy? So when we evaluated this CIPN, which was self-reported by the women in our study before they started the exercise intervention and then after the 6 months, we saw that there was an improvement in this self-reported chemotherapy-induced peripheral neuropathy in those who had completed our exercise intervention. And those who had been in the attention control group actually saw a slight worsening of their symptoms as they were reporting it to us at the end of the study. So this was really indicating to us that among those who have completed chemotherapy and potentially have these symptoms at the start of an exercise intervention, that the exercise intervention can be helpful in reducing the symptoms that they are having.
That's really interesting because, we can imagine that exercise does a lot in terms of improving quality of life, right? It releases endorphins, it makes you feel better. But this idea of the fact that simple walking could actually improve peripheral neuropathy might not be as intuitive. So, Anlan, can you talk a little bit more about why it was that at the beginning of this whole study, you hypothesized that there might have been a link, and maybe talk a little bit more about the intervention itself, and how you measured peripheral neuropathy? It sounds like it was self-reported, but can you talk about why you would think at the outset that these two would be linked? That's just not intuitive.
Yeah, sure. So actually, we hypothesized not specifically walk, but aerobic exercise overall. And there were some potential mechanisms that we hypothesized, like exercise overall can just make the patients feel better. So subjectively, if they are feeling more fit, in that case, they probably will perceive less pain or better quality of life. And because, as Professor Ferrucci mentioned, the primary outcome of this study was quality of life. So we hypothesized neuropathy as one of the mediators on this pathway of how aerobic exercise can improve quality of life. And biologically speaking, there are some moleculars and some biomarkers that can be increased by exercise, and that may have an effect on neuropathy. But I think currently there's no solid biological evidence suggesting any clear pathway this way. So I guess our study also calls for more studies to, like basic science studies, to help review the mechanism of how exercise actually improved peripheral neuropathy. And is there any other way that we can develop other drugs or other forms of exercise that can achieve the same or even better effect of improving neuropathy? And about the specific exercise form that we were looking at, as we mentioned, we focus on home-based moderate intensity aerobic exercise. But most of the women chose to do brisk walking, and that's actually more than 95% of women. And it maybe makes sense because we call ourselves the walk study, so it may sort of leave some impression on them. But some women also chose to do hiking, biking, swimming, or yoga. And as Professor Ferrucci mentioned, we have an American College of Sports Medicine certified cancer exercise trainer that guide them through weekly phone calls to how to improve their physical activity. And we also have this 26-chapter book on exercise and ovarian cancer survivorship that can serve as an additional resource.
So, Leah, was there a particular dose that was significant. So you mentioned that these were women who, in general, had what you call low rates of activity, 90 minutes a week or less. Some might think that 90 minutes is actually quite a bit, but we'll leave that aside. Was there a certain dose? Like, for example, if you did 91 minutes, it wasn't as effective, but if you did 150 minutes, it really was. Did you look at that, and did you find that was impactful?
So we didn't look specifically at dose, but I will say what our goal for women to achieve was that 150 minutes per week, which is the general recommendation out there for all individuals in the population, and also has been translated specifically to cancer survivors as being an important kind of threshold to be thinking about for physical activity levels. And these women were actually very, very successful in increasing their aerobic activity. So I believe it's on average, they had about 160 minutes per week of this moderate to vigorous activity by the end of our intervention. So this was actually very, very exciting to see, right? This is a group that potentially was not doing activity, as you had mentioned at the start, and yet we're able to attain that goal quite early on. And actually, we had very little variation. So most women got up to that high level. So looking at the dose response was actually not even really that possible because everyone was just so successful in attaining that goal in this study. So unfortunately, I can't say if just a small increase would have also seen the same effect because we were seeing such strong increases overall in the women.
How exactly did women do that? I mean, there might be a lot of people who are sitting, listening to the show and saying to themselves, that's fabulous. I mean, these cancer survivors magically got themselves up to over 160 minutes a week. Now, was that due to this trainer that you had? I mean, is that the advice that you would have for people, is to get a trainer? Or, what were some of the perhaps techniques or skills or bits of knowledge that really helped these women to achieve that outcome that perhaps the rest of our listeners in our audience might be able to behoove themselves of?
Well, I'm not an interventionist, so I cannot say much about this. But what I can say is that brisk walking is likely accessible to the vast majority of patients diagnosed with ovarian cancer because it does not require any equipment. And if the patients wanted to do this, they could initiate this form of exercise on their own, well, after obtaining a clearance from their doctors too. But if they need additional resources to help them, to motivate them of actually initiating this form of exercise, then many cancer centers have physical therapists that could be a resource for them. And also, some also have the certified cancer exercise trainers, like the interventionists in our study, could also help them to start aerobic exercise. And for some women, if they prefer to go to the facility instead of doing some home-based exercise, there's the Live Strong program at YMCA, which is a program specific to cancer survivors that incorporate both aerobic and resistance training. So those are all the resources that could be useful to the cancer survivors.
Well, we're going to take a short break for a medical minute, but when we come back, we'll learn more about the role of aerobic exercise in relieving pain for ovarian cancer survivors with my guests, Leah Ferrucci and Anlan Cao.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Breast Cancer provides coordinated state-of-the-art care for patients with benign and malignant diseases of the breast. Learn more at smilowcancerhospital.org. The American Cancer Society estimates that more than 65,000 Americans will be diagnosed with head and neck cancer this year, making up about 4% of all cancers diagnosed. When detected early, however, head and neck cancers are easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for head and neck cancers. Yale Cancer Center was recently awarded grants from the National Institutes of Health to fund the Yale Head and Neck Cancer Specialized Program of Research Excellence, or SPORE, to address critical barriers to treatment of head and neck squamous cell carcinoma due to resistance to immune, DNA-damaging, and targeted therapy. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guests, Dr. Leah Ferrucci and Anlan Cao. We're talking about the role of aerobic exercise in relieving pain for ovarian cancer survivors. And right before the break, we were talking about a recent study that they've done looking at a walking intervention, basically home-based exercise, primarily walking, that actually reduced cancer-induced peripheral neuropathy. And Anlan, maybe you can tell us a little bit more about what exactly is this neuropathy that cancer survivors get.
Yeah, sure. So chemotherapy-induced peripheral neuropathy, or CIPN, biologically speaking, is the damage to neurons that leads to altered perception of touch, pain, sense of position and vibration, or damaged voluntary movement and coordination. So that being said, some typical symptoms of CIPN include like a tingling sensation in hands and feet, or some patients may describe that as pins and needles feeling. Some patients may also experience burning or warm feeling, numbness, weakness, or discomfort or pain. And some may also have less ability to feel hot and cold and cramps in feet. And it's actually highly prevalent for cancer patients who receive chemotherapy to experience neuropathy. And it's actually depend on the chemotherapy regimen, because some drugs are more likely to cause CIPN than others. And so what we are testing is exercise and how exercise can improve CIPN. And that's because so far we only have limited options for how to manage CIPN. We do have one drug, duloxetine, that is the only drug that had enough supportive evidence to be a part of the current guidelines for CIPN management from ASCO, which is a large clinical oncology organization. But it's developed specifically for painful CIPN, and the evidence indicates it only has limited benefits, so it's not a solution to all. And some patients may also use patches, creams, or cooling gloves to help with numbness and tinglings in hands and in feet. But there's not enough evidence so far to support a recommendation on those. And clinically, there's a pretty common approach to reduce CIPN, which is to reduce or delay the chemotherapy that caused CIPN, like paclitaxel in ovarian cancer. So this is pretty effective because you are targeting directly to the cause of CIPN. But this will lead to the patients receiving less than original chemo prescription, or just delayed original prescription, which may negatively impact survival. So this is like the last resort that we don't want to go into if we have other options. And exercise was proved to be effective in improving quality of life in our study, and also in other aspects of cancer survivorship. So we were hoping that maybe exercise could also help us to manage CIPN as well. And as Professor Ferrucci mentioned, we used a self-report questionnaire to measure CIPN that is called the FACT-GOG Neurotoxicity Questionnaire. And it has 11 questions basically asking about the symptoms of CIPN and how the patients feel about like the pain or overall weakness. And the overall range of this questionnaire is from 0 to 44. And what we found was that exercise significantly improved the score by 1.6 points. Yes. And that could translate to a moderate improvement in one symptom, or just slightly improvement in a couple of symptoms. So what we think about that outcome is that it's pretty clinically effective, and it's also statistically effective. So that's why we concluded that aerobic exercise actually can help improve CIPN symptoms.
And so, Leah, kind of expanding on that, right? So if we think that exercise could, reduce peripheral neuropathy, potentially allow patients to continue on a chemotherapy regimen that they may have been intolerant to before. And I know that this study was done in people who had completed chemotherapy, who may have had residual neuropathy. But can you talk a little bit about other studies that you might have done that have looked at, whether exercise really allows patients to be more adherent to their chemotherapeutic regimen, whether in fact we do have any data suggesting that there is an improvement in survival or recurrence-free survival with exercise?
So I think this is sort of a story of more to come, I would say. We have recently, along with Dr. Melinda Irwin, who had led the WALK study originally and has recently completed a study in breast cancer patients during chemotherapy, along with Dr. Tara Sant here at Yale, where they were looking at exercise and diet intervention in breast cancer survivors at the time that they were receiving chemotherapy. Unfortunately, they did not see that it looked like the exercise component or the diet component of the intervention positively impacted the amount of chemotherapy that individuals were able to receive. So that was a question that we were trying to think about. But surprisingly, in that study, we actually had very, very high adherence to chemotherapy overall, which is not what we would have expected kind of looking at historical data. So that's a little bit up in the air if perhaps we ended up enrolling this really adherent group. They were all motivated to kind of be involved in a research study and perhaps had higher chemotherapy adherence than what we would have expected in a wider population. So that was for breast. But in tandem with that work, Dr. Irwin has recently begun a study in ovarian cancer survivors where, again, she's testing a lifestyle intervention that combines both diet and exercise during chemotherapy to see if we can impact that chemotherapy adherence or how well women are able to adhere to their prescription. So that one has just actually started enrollment. And this is actually an exciting one as well to think about CIPN, because this will be a group in which we can see, is exercise potentially also able to prevent that symptom from beginning? So in our current trial, right, we had women who had already completed chemotherapy, already had CIPN at baseline. They were reporting these symptoms to us. But in this new study, we're hoping that we can take a look and see, again, as a secondary outcome, but an important one to think through for hypotheses, can we actually prevent CIPN if they are having exercise during their active treatment phase?
Yeah, I mean, so important when we think about, the massive amount of money that we spend on these drugs, the toxicity of the drugs, to think that something like exercise or diet might actually be able to improve outcomes independently. Is just so enticing. But it is difficult, I think, for people to embrace lifestyle interventions. Nonetheless, I mean, I think these studies are really laudable. So, Anlan, maybe can you talk a little bit about, I mean, what does it take to do studies like this? I mean, it sounds like this is quite the endeavor. Can you talk a little bit more about kind of how you set up a study like this, the team that's involved, the patients that are involved, and for patients who are coming down the pike who might be listening to this show, who might think, geez, I really wish there was a study like that near me. Can you talk a little bit about how patients get involved in clinical trials in general?
Yeah, it is definitely a very important question. But I'm only a PhD student, and I'm more of a research assistant in this sort of studies. So I think maybe Professor Ferrucci might be the better person to answer this question.
Sure, I can take that on. So these are known as our randomized controlled trials, which many people are familiar with more in the context of testing a new treatment or new drug. But we use this same design for testing these lifestyle interventions, where we're trying to enroll a group of individuals who are willing to essentially randomly be assigned to either the intervention or educational program that we are testing, and then our comparison group. So in the WALK study, it had been the exercise was the education and the sort of lifestyle component that we wanted to evaluate, and then we had that in comparison to the attention control. So this is an important thing that we have to describe to potential participants, is that they might get that control condition, but this is a really important piece to understand, right? Is exercise going to improve the outcomes that we're hoping that they improve? improve. So our staff get really well trained in trying to convey the importance of the research, the importance that individuals understand that random chance of being in either group. And then particularly with the walk study, they also had this benefit, even in the control condition, of having contact with our study staff through weekly telephone calls. So they were getting this extra layer of support in a way not tied specifically to exercise content. So that also might have been helpful for this particular study in bringing people into the research component. But as Anlan said, this is a very complicated thing to sort of get off the ground. We have a large research staff. For this particular study, we had about 144 women who enrolled in the study itself, but we had actually screened over 700 individuals to find those people who were not only willing to participate, but also eligible based on some of those criteria we had mentioned before, like having completed their chemotherapy, having that lower level of physical activity at the start. So to just enroll for this one study, it actually took over 4 years. So I would say, to keep in mind that this work, while you can generate a paper, what seems like fairly quickly, the actual background work that goes into it, that in the field piece can take quite a while. And as you can imagine, as we're enrolling participants, we have to have our interventionists ready to be counseling them. So this is not a process where we can enroll all 144 women at one time. So in part, you have that pool of people coming in and sort of a trickle or a rolling process so that you can provide the actual content to them that you're trying to convey, in this case, the exercise counseling and these weekly telephone calls that they received. So I hope that answers a little bit about the design.
Yeah, for sure. I mean, and Anlan, did you find that, if you tell patients that, we're looking at exercise and its potential impact on improving quality of life in cancer survivors, I mean, would that in and of itself, even if you were randomized to the non-intervention arm, the attention control, might those women be more likely to just try a little bit of exercise on their own? And how would that dilute the results, and how would you mitigate against that?
Yeah, definitely. Doing randomized controlled trials, usually the best way to do this is to blind the patients of what kind of intervention that they received. Like if it's a drug trial, then methodologically speaking, we probably will provide women who were randomized to the control group with a placebo. So in that way, they wouldn't know which kind of intervention that they're getting. And that way we can help to get a more valid result. But this is a lifestyle intervention. And like you mentioned, there's no way that we can stop the women from exercising themselves. And actually, that's what we've seen in our study, that women in the control group actually started to elevate their exercise level a little bit as well. But how we deal with it, statistically in our analysis, is that we will consider that this sort of crossover, as what we call in randomized control trial, will bias our result toward null. So because control women started to exercise, that sort of made them more similar to women who were in the exercise arm. So that would make us to observe generally reduced effect size compared to what we would actually have if they did not start exercise at all. So in that case, if we observe a very effective result in the end, then that would mean if everybody adhered to their randomized group, we will actually have an even larger effect size than what we observed. So that's usually how we deal with this sort of crossover in randomized controlled trials.
Anlan Cao is a graduate student, and Dr. Leah Ferrucci is an assistant professor of epidemiology at the Yale School of Public Health. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.